Welcome to today's board meeting. My name is Paul Miller, I'm the chair of the trust, and we'll do introductions when our colleagues at the patient story arrive, if that's okay. Any apologies for today? Donna?
Yes, Joe, we have apologies from Paul Spencer and Selina Stephen.
And we've got a couple of colleagues joining us over Microsoft Teams, so welcome. Any declarations of interest relating to today's agenda? That's great. As I said, our colleagues who will do the patient story are running a little late, so we'll do that item when they arrive. So, and also I'll do the answer to written questions in a bit as well. So, minutes of the previous meeting.
Chair, we just have a couple of corrections in the minutes. Some of them are just minor things where we've got the names of certain things that just need tidying up. One thing I just want to note though is on page 8 under the Quality and Safety Committee Chair's report, we note the CQC investigation to Riverside Ward have been completed. It should have said commence and it is still ongoing. So that's the main thing to note.
So aside from those corrections, any other matters of accuracy relating to the minutes of the 25th of March?
Just on page 5, Chair, point
Yep.
7, the reduction of the stigma for those people armed forces wise, and also about qualification, are two separate things: reducing the stigma and encouraging veterans to contact for support where they need it, whether it's an NHS service or charitable service, as opposed to people qualifying. I probably just need to adjust some of the words, Jenny, in the previous minutes, just to cover that point.
Are colleagues happy with that clarification? So Martin, if you can pick that up with colleagues outside the meeting, and we'll amend that. Jan?
Chair, can I just go back to the previous point that was raised by Donna in terms of the amendments? Does that mean that the rest of that paragraph, is that still correct? Given that, so that the independent review request about young person's parents has been,
that's right.
been concluded?
Yes, that's right. Yeah, thanks, Charlie.
Thank you.
So on that basis, if there aren't any other suggestions of corrections, can we accept the minutes of the meeting on the 25th of March? Then on to matters arising, and that's the log. So 2 items here, and they're both in July. Yeah. So any queries or questions around those, or just wait for them coming through to the board in July? Right.
One question on that.
Yes.
In terms of closing the actions, what kind of level of scrutiny happens on that? So
the level of scrutiny is it goes through whatever, so it relates then to whatever particular action it is. So if it does relate to work that's being done, say, by a committee, then there'll be conversations that Donna would be looking at about the assurance and evidence of that. If it relates to an action of an individual that's coming straight here, again, as and when it comes straight here for reporting, with either written or verbal, it'll be closed up at that stage. It's a key role that Donna has in playing to make sure that we actually are closing this off with evidence. So sometimes events can overtake as well, and we can re-clarify and restate an action, otherwise you end up with like 15 versions of the same thing sometimes. But the key to it is they only get taken off and closed off when there's evidence of completion. In which case then, I'll go back to, we've got some answers to written questions. So if colleagues bear with me, and we've got 3 questions and they're quite lengthy. So, question number 1 from E. Ward on Family, Friends and Carers Charter. What specific key performance indicators, KPIs, are being used to measure the delivery of this charter? How frequently are results reported, and are these being published to ensure transparency? Can you confirm how this charter meets the SMART criteria: specific, measurable, achievable, relevant, recordable, time limited ongoing, particularly in terms of measuring outcomes and time-bound targets. So the response to question 1, and what we'll do is I'll read the response to question 1 and then we'll go across to the patient story. The charter was co-produced by carers as a series of intentional statements for experience. It was not intended that we specifically measure the delivery of the charter through identified SMART outcome and key performance indicators. We therefore do not measure the carers' charter as a standalone piece of work. However, we do measure our engagement with carers and their experience. We do this through following publicly available reports. For example, Trust Board Part 1 in public includes a bi-monthly report covering safety, effectiveness and experience measures, in which carers' engagement is covered by specific questions. Formal and informal complaints are reported in the same way and include those reported through carers. Thirdly, annual triangle of care accreditation, a summary of which is published in our quality accounts. We continually seek to improve the experience of carers and work in partnership with our carers strategy experts by experience group to ensure the voice of lived experience is at the heart of this. So that's our response to the first question from the public. So if it's okay, what we'll do is just pause the other 2 questions to the public and go into the patient story. And can I just check, do you want a few minutes to get a drink, compose yourself, anything?
Is that okay?
Yeah. Yeah, so in which case, I'll carry on with the questions.
Yeah, that'd be great, thank you so much.
That'd be marvellous. Just go get yourself a drink. And also what we'll do is we'll go around and introduce all 4 members of the It's nice to see you.
You too.
Right, question 2 to the board. The following questions have been summarised from the email received from Francesca Palmer A. Given the recent CQC survey shows no improvement and overall ratings requires improvement over many years, what will the board do differently to improve performance, and is external support required to deliver quality improvement? The response. Although the Trust continues to be assessed by CQC as requires improvement under the well-led domains, it continues to see steady improvement across many of the service lines and areas that make up the well-led assessment. Mental Health Act visits to our wards continues to show a steady improvement in service provision, and other assessments such as the staff survey, annual community assessment, financial performance, We Want Great Care, all report improvements. AWP is particularly proud of the increased use of experts by experience and carers' experiences in order to help us transform our services. The Trust Board recognises that it is operating in a difficult operational and financial environment, and therefore its strategy and annual operating plans are focused on continuous improvement of services. The Trust's governance and management structures continue to respond to the pressures and risks that all mental health providers are experiencing, and we are hopeful that the next well-led review will reflect the steady improvement that we are seeing. There's also a second part to the question, which is, how are the strategic co-production group and co-production work impacting on the overall performance of the Trust? And the response to the second part is, the strategic service user and strategic carer expert by experience groups have supported a range of improvements in performance across the Trust, as has our co-production approach embedded through our transformation and improvement work. The following are some examples of recent improvements. Improvements in results of the CQC Community Mental Health Survey in a range of areas, including in overall experience of care, respect, dignity, crisis care and planning. Improvements in care planning and risk assessment processes, aligned to national best practice. The Trust has been nationally recognised as a trailblazer in implementing a new approach to collaborative care planning and individual patient assessment and planning, our safety assessment and personal well-being plan approach under the banner of Your Team, Your Conversation, Your Plan, were all co-produced with service users, carers and staff and are nationally recognised. Established mental health integrated network teams across BNSSG to support improved access to mental health intervention in the community. The approach of these MINT teams has been co-produced with service users, carers and staff. The teams help people to access mental health and wellbeing support more quickly and closer to home, transforming the way that people assess clinical, psychological, social support in their community. Alongside this, a range of new specialist mental health services has been established to improve people's access to evidence-based support. We will continue to support our work of our strategic experts by experience and in co-production through all of our planned transformation programmes. The final and third question for the public for today's meeting, from G. Smith. Please can you tell me why, at a time when the Trust has to save money, you continue to book external venues for the Leadership Forum, claim expenses and plan to hold an awards dinner, which costs the same as someone's job that is likely to be lost? The response. The Trust is acutely aware of the financial pressures it is operating under and the very real impact this has on our staff. All discretionary expenditure is closely scrutinised and significantly reduced as part of our savings programme. The Leadership Forum and Staff Awards are relatively modest in cost when set against the Trust's overall budget. The Staff Awards event, for example, costs approximately £15,000, which represents a small fixed proportion of expenditure and is funded to recognise and retain staff whose work directly supports patient care and service quality. The Leadership Forum is held infrequently and reduced from monthly to just 4 times a year and uses low-cost venues only, where this is more cost-effective or operationally appropriate than on-site options. These meetings maintain leadership cohesion and capability is important, particularly at times of organisational change. We fully appreciate that all non-essential spend can feel difficult to justify during times of financial challenge. However, maintaining staff engagement, leadership capability and morale is an important part of sustaining safe, effective services and supporting our workforce through change. We remain committed to minimising costs wherever possible, whilst ensuring we continue to deliver high quality care for the communities we serve. So that's the 3 questions and comprehensive answers. And apologies for you having to listen to me at length at the start of the meeting. More interesting, however, will be the presentation from Angelina. And before starting, can I go around the room and introduce everybody, if that's okay?
Sure.
So I'm Paul, we know each other, Chair of the Trust.
Yeah.
I'm Dominic, Chief Executive, we've met before.
Okay.
James, one of the non-exec directors.
Hi Angelina, nice to see you in person. Sarah.
Yeah,
I'm Angelina John Baptist Grant, non-exec director.
Hi, Martin. I'm responsible for transformation, estates and digital.
Julian, I'm the HR Director.
I'm Simon, I'm the Finance Director.
Hi, I'm Matthew, I'm the Chief Operating Officer and Deputy Chief Exec.
Hello Angelina, you know me, I'm Sarah.
And I'm Lizzie, I'm a non-executive director as well.
And we know each other, and Angelina's one of our patient safety partners on the patient safety committee.
Yeah. Amazing.
Thank you too.
And Anna, can you introduce yourself to some people who don't know?
I'm a Blaze Experience of Care Manager.
And online we've got 2 non-executives, so Brian first.
Welcome, Angelina. We know each other from quality and safety, but it's Brian, one of the non-execs. Welcome.
And Loveday.
Hi Angelina, we've met online a few times. I'm Loveday, one of the non-execs.
Brilliant. So the floor is yours.
Okay, thank you so much. I was a bit nervous, but I'm going to give it my best shot. So thank you so much for having me to come to speak today. When I heard it was basically I've been meaning to do this for a few months, but I've had some health and stuff going on, so I was going to delay coming to speak to you all. But when I heard it was in Salisbury, I felt like it was a sign, because actually I was sectioned here in the PQ and I haven't been back in 5 years, so as you can imagine I'm quite full of emotions right now. But I thought it would be a really nice way to be able to reframe the situation. So when I was unwell, the PQ in Bristol wasn't actually open, so they brought me here. It was quite a negative thing for me, because actually this is really difficult to talk about, but one of the perpetrators of a paedophile ring that I was a victim of as a child was actually a mental health nurse and a social worker in this area. And he was also a mayor of the town of Wilton, which is 8 miles away. So as you can imagine, it's hard for me to share this, but I feel like by sharing this, it's opening up the door for other people to be able to share it. But as you can imagine, my mind went really wild. I had PTSD at the time, and then went into full-blown psychosis because I felt like I'd been abducted by the people from my childhood, and that I was getting taken away and I was going to be harmed and stuff like that. So when they put me here, out of all of the places, I just thought, what a turn of events. Anyway, as you can imagine, this is a really difficult thing for me to talk about, so I wrote a poem about it that I'm going to share today, if that's okay. Pardon?
Do you want to put your slide?
Yeah, go for it, that'd be great, thank you. So I'm going to try and do it off by heart, but if I get a bit nervous, I might need to.
So you've asked me to record?
Yeah, I've asked her to record, just so I've got, the memory of this. Okay, so this is a poem that I wrote that just helped me process everything that I've been through, I guess. So it's called Torn Between the Lines, and so this shame was never mine to hold. It was such a weight on my soul, waiting for you to show how far you would go to control me. The marks and bruises, I wish they would cut deeper so that someone would see me and free me from your captivity. I used to wonder how it all went unnoticed. Pillars of the community didn't help me. As it transpires, they were involved. They didn't just cast a blind eye, they were sullied in the flames, the same monsters that caused me so much suffering, pain and shame. Sometimes I think it's so bad it can't be true, but it is. Of this I'm too sure too. The memories come back like a stab in the heart. Do I have to remember? I feel like I can't. It's so much worse than I ever could have imagined. How can people do these things? I just can't fathom. Am I the only one that sees it all? It's been a part of my rise and fall. How do I overcome this? What if it breaks me? The night terrors shake me to the core. I can't keep score of all the horrific things that happen to me anymore. It shoots me again, it's all that I see, the memories cut like daggers. How can this be? Will I ever be free from this turmoil and suffering? What's happening to me? All the gaslighting scarred my mind. At worst, I thought I didn't have a friend to find. Despite all of this, I always tried to be kind. Little did I know of the soul family I would find. They protect me from all your abuse, my star family, the family you choose. They treat me with love and cherish my existence. They shower me with care and consistence. So no, you have not broken me. Your horrific words and actions have just served as fuel to the fire within me and my drive to succeed. Creativity heals me, I'm being freed from the demons that haunt me at night. I still see them and feel them out my dreams, they bite. But in spite of your need to destroy me, I've grown back stronger and can be the real me. I feel safe for the first time in my life. I still can't believe it, but I try to be a good person and shine a light for others, so you can free yourself, heal yourself and recover. For me, it was the lack of a mother or father and the unspeakable abuse that I suffered. As an infant, I was alone in the world without a chance. No one looked after me, not even a glance in my direction. The opportunities I missed, I tried to resist the truth as it weighed on my heart and chest. I blocked out the rest in order to survive. I tried to thrive in the most toxic of environments, which stunted my growth and my hope for all to see. Will I ever be free? Consumed by the flames, will I ever be the same? This shame was never mine to hold. Thank you. Thank you so much for listening to that. I thought that was the best way to tell my story in a way that feels safe to me. So as I've been looking into trauma and stuff after everything that happened with my mental health, I realised I had 10 out of 10 of the adverse childhood experiences, which is obviously quite upsetting to hear, as they obviously really significantly, even one, can impact your development. So when I was in hospital, I felt that I had no help for my trauma, specifically for the childhood sexual abuse that I went through. I feel like I had no support, and I don't know if it's still stigmatised or people don't want to trigger that person, but it's a burden that nobody should have to carry on their own. So for me, when I was in hospital, it was like my psychosis was around my trauma, so it's like I was reliving my childhood trauma. especially in Salisbury, as you can imagine, just walking around the areas I would have known before. So 5 years later, I'm getting therapy, which is crazy. Like, I've had to deal with this not only my whole life, but then after being released from hospital 5 years ago, I've only just got art psychotherapy, and they were trying to deny me it, and I made a formal complaint, and that's the only reason that I got it. So I do, speak up for myself, but I do worry about the people that can't advocate, and I haven't always been like this, it's something that I'm learning to do for myself. So I just wanted to let you know, like, how my PTSD manifests, like my complex PTSD, and how awful it actually is, and what I have to live with every day. So just to give a bit of context, like, I still have nightmares about my childhood home, and I left that town when I was 16 years old, so that's 21 years ago. Every night I have like really intense nightmares, I have night terrors, I have intrusive memories like daily. Obviously I'm like trying to heal myself, and I have, I have a really good community, I'm very creative, and I have a lot of coping techniques, but I feel like this is going to be a lifelong work, and I just feel like I could have had a lot more support around that. I've got a great therapist now that I'm building a relationship with, so obviously that's a step in the right direction. So I would say that, like, my complex post-traumatic stress disorder is the sole cause of my psychosis. That was the only reason I got psychosis. I've never had another episode. It was just everything I've repressed that was not safe to come out. It all kind of came out too quickly, and then made me very, very unwell. So I was obviously in the intensive care unit, so I was very, very unwell. But I had like no help or support or intervention or anything when I was younger, and I don't know if that's because I don't know if all of the people around me were involved, or if they were just like not even aware, like even though they were seeing the signs, they weren't acting. Does that make sense? So I do feel like if I had a little bit of support or intervention, maybe things wouldn't have had to get so bad, because I didn't even know I had mental health problems until I got sectioned. So I think that's a bit of a sorry state of affairs, isn't it, that people have to get that bad, and I feel a lot of people feel like that. So so just to say as well, like when I was in hospital, it's given me more CPTSD. So like the way I feel like I was treated quite physically, like I had like bruises all over me from being put in seclusion, and all of my actions, whether I was violent or not, were all fear-based. So it was kind of me just protecting myself, thinking that I was going to get harmed again. So there was no like acknowledgement of any of the stuff I've been through. Nobody was looking, why am I acting in that way? They were just locking me in rooms, which has given me more complex post-traumatic stress disorder. Like I can't sleep in the dark anymore. I can't even sit in an enclosed space, like on the inside of a bus. And things like that. And I from the work that I've been doing with you guys in Seoul and stuff, I've noted that the seclusion in Ashdown, where I was a patient, is actually not fit for purpose, and that is the one that's caused all my issues. So 5 years on, I'm still really traumatised. So I was coming to hospital because I was really unwell, and what I needed was a nurturing space where they helped me to heal my trauma, not give me more trauma. Does that make sense? And now I have to deal with that trauma, so I'm definitely more traumatised from being in hospital. So I do believe that probably many service users have trauma, from what I've heard. That a lot of people have traumatic experiences in their life, potentially charged with sexual abuse. And I just want to open up the conversation for other people to talk about it, because it's such a hard thing, and there's a lot of shame. And as Giselle Pellicott said, shame needs to change sides, and that is what I hope I have shown you with my poem as well. Today I want to advocate for more support for trauma, because I think that is the sole reason that I got so unwell, and I still have to live with that daily, and I think that needs to be improved, because I think every service user has probably had some kind of trauma in their life, from what I understand from the work that I do and stuff. So I do a lot of work for AWP now, which is great, because it feels like I'm kind of giving back and using my story to help other people. So obviously I'm in the CEOG meetings and the QSC meetings as a patient safety partner. I also co-chair the Strategic Service User Group, Experience of Care meetings, creative and editorial work stream as well, which we actually make a newsletter for that we have today, I believe. And we also put on an event in Bath to showcase artwork from people with lived experience of mental health, and I performed some of my rap there, which was amazing. I also helped to develop a therapy for the early intervention team, which was great, because that was like my old mental health team, so it was nice to like work with clinicians, and it was like a walking therapy for people that have psychosis. And I not only did I help develop it, I went on the walks as well, and that was so great, because there was that kind of unity, because there was somebody that wasn't just a staff member, somebody that had lived through it, so that was really amazing. And my favourite of all things I probably do is the training that I do at Cullington Road, like the regular one, working therapeutically on wards. So that's been amazing for me, because it's given me a chance to reframe a place that was such a negative for me at the time. And now I'd say it's a 95% positive, which is amazing, because I've achieved that all of the people I've taught there as a lived experience trainer. And also, I even bumped into my psychiatrist, and the first time I totally avoided him because I was like, oh god, he could normally lock me up, so I didn't want to speak to him. It was just kind of triggering seeing him, you know. So it kind of brought back those feelings of not being able to leave when I wanted. But then the next time I thought, you know, I'm going to approach him, and I approached him, and I was like, remember me? I actually work here with Megan now, leading the training. And he was just like, what a success story. And now we acknowledge each other, which is really nice. I often bump into clinicians that actually help me, and the most recent training I did, there was 2 people on it, and obviously when I was in hospital, just to mention as well, it was COVID, so everyone had masks on, which made it even worse. But when I was in the training, I didn't recognise, I basically write like music about mental health, which I'll be sharing some in a minute, but I was sharing some of my music and they were crying straight away, and I was thinking, oh wow, they started to cry early, but then I realised I actually knew them. But it took me a while until they started speaking. It's obviously like till I saw their mannerisms and stuff. And they used to be healthcare assistants, and they're now nurses, and it was just amazing. And they were like, it's just so nice to see someone shining, someone at their potential. They said, whenever I feel like my job isn't going anywhere, I'm going to think that people can get better. And also, I felt like it was a really special interaction because I was able to tell them what had happened to me to make me unwell, number one, what I was experiencing when I was unwell and how it felt, and like the delusions I was having. And I was quite emotional for about a week after, because I just thought, when do people ever have that opportunity? So I feel like that is just so important, like lived experience training as well. And for me, I've reframed that hospital, and that's why I wanted to come to Salisbury today, even though I was quite nervous, I was quite curious as well, to be honest, but I just thought if I could reframe this hospital in the same way, that would be an amazing thing. The other thing that I want to advocate for is creativity for well-being. So that poem for me that I just shared with you, that helped me to sum up something that's just indescribable and awful and horrific, and it helped me even make sense of it myself. And I literally wrote that poem out in one go. It just flowed out of me, no editing. It was just something that I feel like I need to get out. And then also it gives me a way to be able to articulate what happened to me without, you know, in a way that feels safe or in a creative way. So I just think creativity, without creativity I don't think I would have recovered in the way that I have, and I don't think I would even maybe be here to tell the tale of what I've been through. You know, it's always been my outlet. From a little kid I used to sing and write and stuff like that, and that was like my refuge, you know. So I absolutely love pretty much all creativity. So I sing, I rap, I act, I dance, I love being on stage. I'm going to share a rap with you now called Against All Odds, and it's basically about all of the positive things that people have said to me on my journey that have helped me. I've like tried to put it into a rap, and then also it's about not letting statistics define who you are. So I had a psychiatrist say to me, you have 80% chance of getting on well again. And then I went away and I worked it out, and actually, of getting psychosis again, sorry. So I went and worked it out, and 40% of people actually get their first episode in the first year, 20% is over the next 3 to 4 years, and I was at 3 years nearly, and 20% is over the trajectory of their life. So I was like, actually, no, I've got a 20% chance. And I went back and told the psychiatrist that. And she was like, do you think we shouldn't tell people this? And I was like, well, you could have started off a bit more positively and say there is a chance, but, you know, so yeah, this rap is about that as well, like not letting people's statistics define who you are. So yeah, I'm going to do that now. Thank you. Just give me a sec to, is that alright? I'm just a bit of water into just, I'll probably stand up to do it, if that's alright.
It's fun.
Okay. Huh? Thank you. Okay, I'll just give you this. Oh, okay. People say they've never seen anyone like me, trying to be the best me that I could truly be. Get told I'm positive, that's what gets me through. It's my hard work and sheer determination too. I see the best in things and rise to any challenge, but through the darkest times, most people can't imagine. They locked me up, like they threw away the key, seeing things undeniable, mentally and physically. Statistics are against you, I get told from time to time. Decide to disagree and make this mission mine. Show you can always get better and be brighter. Survival, walking miracle, and a fighter. I see the positive, claiming my recovery, making my life all it can be. They plan for my demise, which they will never see. Like a phoenix, I will rise so spectacularly. Always asked, what got you through? It's creativity, support, and willpower too. Put my mind to things, I always will achieve. Such strength within me helps me to proceed. Want to show we can go on and thrive. Been through the darkest times, now I'm more alive. It's my time to shine. I'm better than I was before, I will not be defined. Psychosis makes you crazy, you will never recover. Misconceptions that I've heard from others, I choose to rise above it, I don't believe the words. Psychosis is dangerous, a misconception that I've heard. What was real, it was such an ordeal, hearing voices in my mind, so glad that now I'm fine. Speak about how I feel, I'll keep it all inside, can be vulnerable and shine at the same time. Training staff to help others to recover, it's a feeling like no other. So many people tell me they're so proud. Since my crisis, life has turned around. I keep rising, I'm here to shine. I'm coming for my future, no, it will be divine. I will not be a statistic, you can heal your mind. Believe you can achieve, your future will be bright. I wanna be defined like a phoenix, I will rise. I wanna be defined. What's the secret? I've been asked before. Optimism and belief broke down every door. What's your advice? Professionals want to know. How did we prevail and thrive and grow? Never seen a comeback quite so strong. I found my people and where I belong. I sing my song proud, write raps to help others. Better than I was before, I've gone on to recover. A remarkable person, my psychiatrist said. Such a bright future she sees ahead. Exploding and grown, inspiration to many. Using my gifts, it's my time and I'm ready. Overcome adversity, find myself again. Fulfill my potential to its full extent. Strongest willpower you've ever seen. I'll overcome it all, no stopping me. Story so incredible, proud to be me. Next stop, TED Talk, there you'll see me. Little Miss Sunshine is what they call me. Shine my light so brightly, it's who I'm meant to be. I'll never forget people there in darkest hour. Help me find myself again, supported and empowered. I'm back to myself, doing better than ever. Whole experience will shape me forever. Using my story to inspire others, show you can heal, prosper and recover. Breaking down stigma one rap at a time. Come back from anything, go on to shine. Recovery isn't linear, one step at a time. Even when struggling, you can go on to thrive. Power in my journey, overcame it all. Light in the darkness, rise after the fall. Still making sense of the difficult times. Again and again, I've gone on to rise. I've achieved things I never thought possible. Even training staff at the same hospital I was a patient at for 3 months. To me that means the battle's been won. Excited for the future, the best is yet to come. There's more to my story, I've only just begun. Odds against me, I've gone on to excel. I've come back from the depths of hell. A vision of hope, the fire you see. I've conquered it all, my light set me free. I wanna be defined like a phoenix, I will rise. I wanna be defined, I wanna be defined like a phoenix, I will rise. I wanna be defined. Thank you so much. Before I forget, if anything resonated with you, feel free to get in touch. My email's on the handouts that we're going to give out. Thank you so much.
Wow. Wow. Well, how do we follow that?
With the ramp.
No, you heard me sing on Monday? No. The purpose of the patient story is to ground you. It's not to comment on the detail. It's to ground people for the meetings that we have when we talk about all this stuff. But yeah, blown away.
Thank you.
Any thoughts, Jan?
Absolutely phenomenal. Thank you. I think this is probably one of those powerful patient stories that we've had. And I've been on the board for 6 years, almost 6 years, so thank you for that. A question, and you had a line in your rap actually, when you said, healthcare providers will ask me what could we do better. I'm reframing that a bit.
What's the secret, that one?
What's the secret? That was it, yeah, thank you. You know your rap better than me. But yeah, what can we do better? Because of the fact that this is such a, I've written down here, how can we support, or what can we do differently when we're supporting service users who are vulnerable and are admitted for their own safety? But what can we do to prevent additional trauma?
Well, I think like looking into their background a bit more, because I don't feel like that was done with me at all. I don't know, I mean, I didn't even really know that I had complex PTSD at the time, so it's tricky. But also, I'd say what helped me most out of anything was the people that like gave me 5 minutes to like reconnect with who I was. Does that make sense? So that like people that actually looked at my skills, interests, that is the most significant bonds that I made in hospital. Like, for example, there was an occupational therapist who was Spanish, and he found out I spoke fluent Spanish, and so he was like bringing me all this homework, and at first I was like, that's so easy, and then he finally brought me something, and so we like bonded over that, and then I could kind of trust him in other ways, even though I would still have my delusions. He was the person that I didn't really feel that safe with anyone, but I could have felt more safe with him, but that was because of my psychosis, you know. So yeah, I feel like just kind of, because with me, like the worst thing you can do with someone with complex PTSD is lock them in a room. That just made, like, I even tried to like end my life, to be honest, when I was in the PQM 136, because I was so distraught that I'd been kidnapped and stuff, and I was going to get hurt, you know. So yeah, so it's quite a difficult question, isn't it? But I guess just because I think patients shouldn't be coming in and having more trauma. Mm-hmm. So I thought it was maybe like looking into their past, but helping them reconnect. So I think like that grounding helped me to like, because also Spanish I'd learned it as a skill as an adult, so that helped me to ground and orient myself. So I feel like that can help people, because they won't, you know, maybe act in the most aggressive way. If somebody's feeling a bit more calm and like reconnected with themselves, does that make sense? Or if there's something that they feel they can trust because they bonded with them, giving them that 5 minutes. Yeah, quite a big question, I guess. I hope I answered it.
No, you've answered it. Yeah. In my mind, there's something about that rapport and the communication, and I think it's the rapport that I've picked up on that actually helps to ground you, and it may do that for others. Obviously, everybody's not the same, but it may be a start. So thank you for that.
Well, it's just looking at who somebody is, like what their interests are, what their skills are, who's dear to them, the things that are dear to them. Because I think that's going to help people to reconnect with themselves and get better. So thank you.
Thank you.
So for me, two things. Courage for me is quite often an overused phrase. You just exemplify courage to me. And then the other thing that came out of your answer, but also came out of your art, is the importance of trust. Mm-hmm. And when I go around and ask clinical staff, you know, what is it what we do that makes people better or helps them, quite often the answer is trust. Mm-hmm. So that magic word, how do you build trust? If it isn't trust in the relationship, I don't think the therapeutic magic happens.
No. Like that person that looked into, I still don't know how he found out that I was even fluent in Spanish, you know. I'm like, did he look in my notes? Did I start speaking to it? But it's, you know, that is somebody really going and looking into who that person is, isn't it? And that really helped me to connect with him, so, yeah.
How do you feel now, having confronted your fears and done this and blown us all away?
I feel like that, yeah, I feel good. It was nerve-wracking, especially because it's in Salisbury, but I felt like it was a sign. I felt like I should come and it would give me an opportunity to, I feel pretty good. I was really nervous when I walked in. It's kind of anticipated now, yeah, thank you.
So I've got Love Day and then Simon.
No.
Sorry, you've got Love Day.
I thought it was amazing. Thank you so much. The thing that really, really struck me is the way that you found your voice through creativity in that channel. And I just wonder what interventions or volunteer groups there are that can help and support others who might equally find their voice in that means. Or was it just something that you managed to do yourself through your other connections? Or is there something that we as a trust could look at that would help people like you?
Well, so I've always been a creative person, but I've definitely leaned into it since I got out of hospital. But for example, my mental health group, the EI team, my mental health team at the time, the EI group, they had a music group at the Trinity Centre. I actually got to perform there, which is what these pictures are of actually as well. And that was just after I got out of hospital, but it was no other service users turned up, so it was just me and like clinicians that I worked with, like just playing my music. So that was amazing. That got me back into music. I think that was when I started to get better, to be honest, because I was like reigniting that passion I already had. It was having me re-engage myself. I've also been in like a mental health drama group that's just a charity. And we've performed like at Old Vic, like loads of other places as well. So yeah, there are a lot of things out there, but I think I was already very creative and always writing and stuff, but I think I've definitely used it and leaned into using it more as a tool to express like my mental health and the trauma that I've been through and like overcoming it. And I hope that like my music, because it is intense, it is like makes you feel vulnerable sharing this kind of stuff, but I do it in the hope that somebody might connect. Because I feel like when I had my psychosis, there was no one out there really talking about it. There was nobody that had been through what I'd been through. I had no idea what was happening to me, you know. So I feel like even if I normalise it by saying the words, then that might make it better for someone else, you know. So, and it also helps me in that process as well. Thank you.
I think you said it yourself in the rep. You can be vulnerable and shiny at the same time.
Yeah. Yeah.
Julian.
Hi, thank you for that. It's really, really good to hear this amazing story. I'm really interested in what you said you were in for 3 months in Ashtown. When you come
I
out,
was 1 month, sorry, in the Pico, and then 2.5 months in Callington Road.
Okay,
Yeah.
okay. When you come out of our services, so you go from being in wards, and then you leave.
So it wasn't actually any better. So I thought it was going to be better, but I still had all of the like psychosis and delusions, and I didn't trust my family and friends. You know, a hard few months where I probably had psychosis for like 6 months in total, like even like 3 months after I got out of hospital. So you think that you're going to get this respite and suddenly you're going to be fine. I was so excited when I got told, but all I would walk around the hospital saying is I want to go home, I want to go home, I want to go home, constantly, you know. And because for me being locked up was so intense, especially because I had complex trauma from my childhood where you get like, you know, you don't have autonomy or control over, so it felt like that situation. But yeah, it's not like a magic fix. When you get out, there's like 3 months of me being very unwell, and luckily I have like a community of people around me, including my sisters and friends that I've made over the years that were like all just supporting me, like looking after me, and like never gave up on me. And I'll never forget that, you know. I think that I was in a fortunate situation because not everybody has that, so I can't imagine how somebody would feel that doesn't have that strong community that I'd already built. So
did AWP staff continue to quite quickly help you, or
I would say so, yeah. I mean, I had a care coordinator from when I was in hospital, and I had her for like 2 to 3 years, and she was really great. But still, I was very paranoid when I got out of hospital. It was hard to trust anyone for a while, you know. So, but yeah, I would say the early intervention team. I've had an 80% good experience with care teams in the community, but I have had some bad experiences as well, and I just changed care coordinators now. I'm like, no, that's not the person for me. Can I have another one? And it can feel scary because you think, oh, is this going to be a bad decision? Am I going to get someone worse? But I just try and trust myself now and advocate for myself. So, yeah, because I think we all deserve to get the best services, right?
Yeah.
So, yeah, thank you.
That's really interesting.
Well, I said, you know, I've sat through a few patient stories now, and so have you. I can sense when the ball was blown away. So that's a slam dunk. That's orientated us to what it's all about. So thank you.
Okay.
And yeah, I hope the journey back is nice in the sunshine and showers.
Thank you so much. There's a few handouts here for us. Yeah, great. Thank you.
Thank you.
Very good.
I first met him.
Wow. As Donna said, follow that. Right. Well, that is what it's meant to do, isn't it? So, we've gone pretty well through the agenda. So we are now on the executive board report.
Sorry, so just on the...
Oh, no, that's okay.
So the Chief Executive Board report, I think, is self-explanatory this month, describes the business that we've undertaken and is well documented there. What I did want to do is just mention a couple of contextual pieces, some of which I'm sure we'll pick up in part 2, but I see no reason not to flag them here. Obviously, the business of the Trust, the sort of day-to-day business carries on, and there's a lot going on. But as everybody will be aware, we're facing particular demand pressures in the Bristol, North Somerset and South Gloucestershire system at the moment. We've seen admissions balloon over the past month, and that's had a sort of concomitant pressure on out-of-area placements, which have ballooned also. We're confident that we're doing everything we can and need to bring that back into line and to provide good care for patients as well. But it's a really stressful situation for those involved. I've also taken the unusual step, it's a step I've only done I think once before, of writing to system partners and asking them to focus on their escalations, which has had a mixed response. 2 local authorities, I'm informed, have responded well. One hasn't yet, so we're going to follow that up. But there's no evidence that that's really moving the dial, but at least they're giving it their attention and focusing on it. So hopefully that will help. The second thing I just wanted to mention, which is covered in the report under point 20 transformation priorities, but just to highlight and remind the non-execs where we are in the process, and again we can spend more time on this afternoon. We're busy collating what we're calling transformation blueprints, so they're a series of change documents that say these are the areas we need to focus on in order to deliver both the quality of care that we want and the staff experience that we need in order to provide that care, give people a good working environment, but also deliver the savings that we need. The executive team received yesterday the first 2 of those blueprints in draft form, and we had a workshop on them to discuss. And the headline would be, there's really good engagement and really good work, but they're not there yet. And that's only 2 out of, I think, 10 thereabouts. So there's more work to do, and we can talk about that a bit more this afternoon. But what's really good is that people are really engaging with the process and getting the analysis done, thinking through the options and starting to move towards solutions. But can we put our finger on, so therefore we're going to do this, which is going to generate that result by that date? No, not yet, but we're moving forwards. So there's an awful lot going on, and people are really, I hate to use the busy word because we're always busy, we always have been and we always will be, but it does feel like this is a time when there is just multiple agendas running simultaneously, which is increasing the cognitive load for everybody at the moment. But we've got really great teams doing really great work, so I'm hopeful and indeed optimistic and confident that we'll rise to the challenges on the table and push through. So that's probably pretty much all I was going to say. Obviously happy to take comments, questions both on the report, on the couple of things I've highlighted. We'll do more, I think, in part 2, and also anything else that people are aware of that they wanted to ask for a sort of formal comment on. Lizzie.
Thank you, Dominic. I wanted to better understand paragraph 18, which is about the trust response to the recommendations in relation to BC, and I didn't understand. And apologies, I didn't understand the sentence about gaps in assurance related to the implementation of the risk of disengagement flag. That's probably a technical thing. There's something on Rio, and I'm not sure that I understand how that is working.
So Sarah James.
So I can talk you through that. So one of the actions taken by the team at Nottinghamshire was to change their electronic patient record so that there is a kind of flag. So when you go into somebody's record and they are identified risk of disengagement, there's something that kind of pops up, if you like, immediately. So any team that's then working with that person can immediately see that this is somebody who is at risk of disengagement. And then they can go to the safety assessment and the personal wellbeing plan to find out more about what do we do in those circumstances and what are the escalations. So we've undertaken that digital change in the Rio system, but that came online in February this year, so it's still relatively new. We've done training sessions with our staff and awareness raising sessions, and we are starting to see uptake of that. So I think when we talked about this at Quality and Safety Committee recently, I think we were up to just over 200 flags that were active in the system, but we would expect it, based on the prevalence of those people who might be in this category, we're expecting it to be around 10 to 15% of our core caseloads should have some sort of flag. As yet, therefore, we're not able to give the assurance to the board that that has been fully implemented. But we have timescales for that implementation, and we're expecting to see that reach the sorts of levels that we're expecting, although it's not an absolute, in June this year, by the end of June, at which point we'll then be able to undertake a clinical audit to check whether the appropriate guidance support has been in place to support those people, or if they have been discharged from services, that discharge has followed our processes.
Thank you, Sarah. That helps me to understand the process, which is where I was muddled. Thank you.
Ela?
Sarah, perhaps you might want to say a little bit about the mitigations that are in place, so that whilst we're still waiting for the flags to be put on the system, it doesn't mean, I hope, that the conversations aren't happening and the interventions aren't happening that are required. So you might want to say a little bit about that, because we asked about that in QSC as well.
No, absolutely. So this work has been ongoing for quite some time, since the publication of the CQC Special Review. So the Rio flag is only one part of the action. There's been significant work done to strengthen our approaches to safety assessment, and then our planning and our safety planning with people, which is very much around how we recognise where there is a risk of disengagement and how we support those people. Those pieces of work have been co-produced as well. We have done some audits of caseloads as well to again help us to identify where we might have those people who are at risk of disengagement, and then being able to kind of implement those kind of enhanced levels, I suppose, of planning and assessment for those people. We have done some gap analysis as well against what we would call assertive outreach approaches, and that was part of a national submission that we needed to make via our ICB colleagues that did identify gaps in resourcing if we were to implement a full assertive outreach model across the trust. As yet there has been no indication that the national team are wishing to implement that, but what we are expecting is that there will be the elements of that that we need to implement that will come through as part of the new modern service framework, which we are expecting soon.
Jan?
Thank you. Sarah, it's to you again, Valerie Dominic. And it is around the MASH, so paragraph 11. Just concerns or curiosity rather than concerns in relation to AWP hosting the MASH function. I've been asked to host it. Oh, is this paragraph incorrect then?
I'll explain, Jan, that's absolutely no problem at all. We had in fact this
conversation.
conversation.
What MASH is as well.
Of course I can. Absolutely. So it's the multi-agency safeguarding hub is the MASH. It is the responsibility of the local authorities, and remains the responsibility of the local authorities, to give you that reassurance, Jan. What they did in BNSSG-ICB is a pilot whereby there was some additional funding to support a worker to basically gather up the information from health partners to take to the local authority MASH. That was hosted within the ICB initially, and that's been a really successful pilot. From an AWP perspective, we used that function a lot. So, as you can imagine, a tremendous amount of requests from the MASH for information about people often relate to people with mental health problems, and therefore the burden on our safeguarding team to respond to that was quite significant. So this really helped us. The ICB felt that the post and the function would be better placed within one of the delivery partners, not within the ICB. And as we were the greatest user of that function, if you like, then we agreed to basically lift and shift that function. So we've taken it, but we are not responsible for MASH. I can appreciate, however, you're wanting to clarify that, Jan.
Thank you. And also you've clarified something else I was going to ask, because my concern was around the capacity of the safeguarding team. Yeah. But I think I've just heard you say that a resource comes with this.
It does.
So there's not additional demand on the already stretched team.
No.
Thank you.
Okay, James?
Paragraph 19 talks about the safeguarding audit. Now, I might well have missed it. The rating of that report was, it'd be good to get a bit more.
I can cover that again. That's fine. So the audit was a partial assurance audit, and there were two particular areas which were gaps, both of which were already recognised and known.
Sorry, carry on.
The first related to our compliance levels with safeguarding adult level 3 training. This was an issue that was recognised when we had our well-led inspection from the CQC, and we've been rectifying since, but our compliance level was not up to meeting the target yet, so that was one of the areas that RSM identified. And the second was with respect to basically a safeguarding database. So currently the team use spreadsheets, they have been doing for some time, recognise risk within the organisation, but we've already been working with our digital team to identify a solution, but had not yet implemented the solution. So both actions were already underway, and in fact we actually escalated a risk with relation to the safeguarding data system to the corporate risk register in response to the audit as well. We expect the actions to be closed by, this is off the top of my head so I might get this slightly wrong, but I think it's by June this year.
Thank you. That's a nice segue into my next question on the corporate risk register. I saw that inpatient flow it's mentioned quite a few times. How is that reflected in the corporate risk register?
We'll be coming on to that in a minute.
Yeah. Okay.
So, any other questions? So the only question I've got relates to the suite of work around the development campaign in Nottinghamshire. So it's all going through the Quality and Safety Committee, which is great. Can you give some thought to how that then comes back to the board at some time and in some format that you think is appropriate? I have a sense that given the nature of it and the importance of it, rather than just to highlight reports, we might want some feedback to the board. It could be in board paper, it could be in a development session, it could be whatever. Can I leave that with you, what the closing of the loop looks like on the Nottinghamshire Valley Campaign sort of suite of reports and work. Right, on now to risk reports. Simon and Donna.
Thanks. Shall I? Yeah, no, that's fine. So I think what's important, again, particularly for yourself, James, is that the summary sort of here, all of the individual sort of risk would have gone through the relevant sort of committees, and obviously the detail of those sort of corporate risk would have been sort of within that. So I think you've seen the Finance Committee papers for March, obviously those would have been sort of in there. Again, the other thing which has been sort of picked up by sort of colleagues is about just the date in which some of these corporate risks were sort of set up, and the fact that they've been there for a number of years. And I think probably reflects the nature of that it is a corporate risk, and something which, although we continue to try and respond to, so finance is a really good example. The financial sustainability of the organisation continues to be challenged, which is part of the overall national financial position of the NHS, and that's why it continues to be a corporate risk for the organisation, because obviously you are expected to deliver from one year to the next. But clearly that risk was put in back in 2016 when I actually first started back in the trust, and reflects obviously the challenges that we sort of continue to have, and I think that's reflective of all of the elements. In respect to this particular area, we've got one risk which has reduced, which obviously associated with the new immigration legislation. That risk has been reduced because of the success of some of our local recruitment that we've done here, particularly down here in Salisbury, where there was a really good recruitment event sort of 6 weeks ago, sort of 4-6 weeks ago, where the interest for healthcare support workers was considerable, and therefore our need to continue with international recruitment and also mitigate some of the risks around the restrictions on the new sponsorship that we can sort of do, given the fact that we've now got a cap that we have to work with, and hopefully we'll be able to mitigate some of the risks that we were talking about a number of months ago. And again, that's supported with why that risk was reduced. And then areas where we've got sort of increased risk, and then again, sort of one around our environmental area, and that reflects the glazing film on the windows and the sort of doors within our wards, and then the second one associated with the sort of safeguarding sort of case. All of the other elements are sort of continued and are scored the same. Obviously, it is reported in Appendix 1. And again, we continue to have really good engagement in respect to not only the corporate risk, but then down into the divisions and into the localities. One of the particular areas which we're focused on at the moment is any risk that is on the system at the moment which has no actions linked to it. And again, we picked up some of those areas. The exec team through into the divisions and to the localities are reviewing those and ensuring that all of our risks, whatever level they are within the organisation, that they do have an appropriate action, and where possible being able to close those if they're not deemed to be an issue that continues to have a risk. Happy to take questions.
And just to confirm that the process for managing these risks is quite embedded now. They go through committees, they go through various executive groups. So this is not just here in splendid isolation. This is the tip of the iceberg. There's a lot of process supporting all of
and obviously that process is then tested through Audit and Risk Committee. We continue to have a division sort of and a corporate department sort of come to Audit and Risk Committee on a rota basis to be able to describe about the risk process. And again, sort of the chair of Audit and Risk, will be able to articulate that, and that's picked up in the sort of report from Audit and Risk Committee.
Right. So, Loveday.
Yeah, thank you, Simon. One of the things that with the discussions we had in TED committee last month was around actually the target score. So we were talking particularly around cyber and whether actually there is ever a realistic thing that you can do that makes that risk get down to the target, and thinking about, re-examining that. So I suppose my challenge on Annex 1 is really whether the target scores in all of those cases are realistic, and you can say, yes, there are some defined actions that would get us from A to B, or is it just a symptom of the world we live in? And my second question on risks is, given the delay in the transformation blueprints, which I completely understand is the need for executive engagement and to get it right, does that play into an increasing risk score around the financial savings, or are you content leaving that at the level that it is?
Simon?
So if I pick up the second one for start, so as I've described before, I'm confident that we will deliver 26-27, which will be a mixture of the delivery of our recurrent savings, slippage on particularly the areas around our transformation and the elements which are still deemed to be unidentified that can be covered non-recurrently. The challenge will then start to roll over into 27, 28, and 28, 29, because that financial flexibility will have diminished. And therefore, that's why we've got a different risk score. So the corporate risk, in my mind, is about the delivery in this financial year. The board assurance framework and the link to the long-term financial strategy, that's why that's scoring a higher level, because I think we would all share the financial challenge and the financial stability of the organisation is going to be challenged over the next 3 years.
Happy with that?
Oh, and then the second one about the first question, which was around the cyber security, absolutely recognise the aspects around the sort of target score. Cyber security, I think, we know that the cyber criminals and opportunists are always one step in front of the controls and the processes which we sort of put in place to be able to mitigate those sort of risks. I think it is something which we do need to review, because again, some of those target scores are probably quite historic now. So again, happy to take an action associated with that and linking that into discussions which you have within the subcommittees about what would be appropriate and acceptable in respect to those target scores. I think from cyber perspective, I don't think we will ever see a situation where we've mitigated the risks around cyber, for example.
I was just going to add to that around risk appetite, because at the moment we're reviewing the risk appetite levels for each of the strategic areas, and Vicky, our risk lead, and I will develop some guidance aligned to that risk appetite with how to set the target scores, so that will help with that process.
So mindful of time then, Martin?
Just to say, from the conversation we had at the Transformation Stage and Digital Committee, because quite a few of the risks are within this particular area, we are, and I think as part of the process, reviewing those target risk scores, and I think that's the important bit. Although we might not be able to get down to where we've said originally as our target, what we have got is the process in place now that reviews that and produces the evidence to say we're not going to get that, so we're going to have to reassess.
Final comment on this paper.
On Appendix 1, it gives a good view back of about sort of 5 months and shows quite a lot of stability, not much movement in terms of that risk profile. Do we have anything that gives a sense of what the aged analysis would look like, which risks have been outstanding or stayed static for the longest time?
I think, as I described sort of in the introduction, you know, the corporate risk register in the main reflects you know, some of the really deep-rooted risks that the organisation's having to work with, and then is reflected in things like our CQC scoring. We know that if you had a blank piece of paper, we wouldn't design or locate some of our inpatient sort of wards in the way that it is now. Our ability to be able to mitigate that and be able to to have the capital funds to be able to do that change, dare I say, have a campus sort of construct within the BSW arena similar to BNSSG at this point in time is a long way off. And hence why these risks and then when the date was actually sort of put in place, they do continue. Clearly we chip away at them. But I think being able to absolutely get to a place where that your environments are wholly safe and fit for purpose, it's unlikely that we will ever get to that place.
Is it fair to say then on that appendix some of those risks are accepted at that level, whereas some you are still working to bring that down?
Yeah, I think whether again it's that definition we accept the current environment as it is at the moment because we don't have an easy ability to be able to influence that. However, when we get the opportunity to be able to bid for work and for monies, then we absolutely jump with sort of that. So in purest sense, you could say, well, actually, a number of these we've accepted those, and then they wouldn't be on here. But then the next question would be coming to say, well, hang on, your in-month financial position say you've got a financial challenge. Why haven't we got a corporate risk which is showing that you've got a financial challenge? So it's
we don't pick it up on line. It'd be good to understand the
CQC that's a really interesting one because when they come in to be able to interview the board and individuals, they will be absolutely using the corporate risk register as their point of reference in respect to the questions which you're doing. So therefore, it's probably in our best interest to ensure that the corporate risk register does reflect the key elements that us as a board are focused in on.
Yeah, we can talk about it offline.
Yeah, definitely. Right, so good conversation, we've got processes, and the conversations will no doubt continue. So, on now to our outstanding care and the Quality and Safety Committee Chair's reports.
So, colleagues, you have two reports here, one from the 1st of April and the other one from the 29th of April. Some of this might feel repetitious because I might have said given some of this information in previous meetings. The thing that struck me as I was rereading my chair's report and the board papers is the theme that continues right through the report from Dominic's report, talking about some of the quality issues that have been raised in this report, right through as we come to some of the other papers. So if I start with the 1st of April report, the thing that I want to particularly draw your attention to in this report is You already know this, the Talking Therapies contract performance risk was lifted, and we were really pleased to see that. The issues of bed flow and inpatient flow and pressures around those are felt and picked up through the quality committee feedback from CEOC, but also the resulting impact then in terms of how staff are experiencing the pressures and how patients are feeling about the way in which their care is received. We are new to having patient safety partners on our committee, and we are learning how to manage that inclusivity. And I think this was our second meeting, and there were some tensions in terms of me trying to manage time and patient safety partners wanting to contribute and new members wanting to contribute. And so we had a very good discussion after the meeting with patient safety partners, who were very upfront and honest about the way in which they felt. So one of them had felt like she had been curtailed, and so we had a conversation about how that would work. And it's served to help us for the following meeting, because at the end of the following meeting we still managed to stick to time. I think we were 2 minutes over or something like that, but they felt that their voices had been heard. And just like you felt grounded by today's meeting in quality and safety, we feel very grounded when we get asked the pertinent question in ways that can only come from somebody who's actually experienced the services themselves. So I'm commending that to the transformation program in terms of involvement, and maybe one day we will see more of that at board level. But it is work in progress. The Learning from Death's Q3 report you have as part of this suite of papers, so I'm not going to dwell on that. And the risk around the glazing works that are required, and the new approach that's been taken around all environmental issues, which is find and fix, is welcomed through in the Quality and Safety Committee, but we also recognise that mitigations are in place. We understand that this was a near miss. It identified for us the work that's required and being picked up through, oversight is being picked up through the Environment, the TED Committee, but we are keeping an eye on it through quality and safety. If we come to the end of April report, you've already heard some of the significant things that we talked about in this report through Dominic's report, and Sarah has updated us, particularly in relation to the work relating to safeguarding and the work that's required in response to the Nottingham inquiry. But I do want to draw your attention to we've had some further discussions and some further assurances around the recent child safeguarding practice mental health homicide review, whereby we were told that whilst good progress had been made, that some actions had slipped. We're clear around the bed constraints impacting on some of those actions, where we have seen the impact of some of those actions. So, for example, using mixed-sex accommodation in ways that we would not usually use them, but because of the bed flow pressures, we've had to do that. Again, working with partners, particularly around some of the interpretation services, multi-agency work around mental health act assessments, all of those things coming together. So we have agreed that we have a partial assurance rating. Some good things in the report that I want to commend to you. It was great to have a chaplaincy annual report, which was really positive. We recognised the issues of constraint in terms of resource, but we're really interested to see the way in which the team were thinking about how they could innovatively use the resources around them. And whilst we had a partial assurance with improvements required around our health and safety biannual report, those of you who've been here long enough will recognise that this was an area that we weren't entirely sighted on. We have now got robust plans in place, robust actions in place and oversight in place, and so we will continue to monitor the delivery of health and safety through that reporting. I also want to commend the CQC report to you, and this is an area that's particularly close to my heart, because when we first started out, we've had CQC visits. Sarah's team were very good at bringing together all of the actions that were required. We now have oversight in terms of where we are with all of those actions, and we have assurance that outstanding actions will be closed by the end of June. I think I'm right in saying that, Sarah. And finally, to say that whilst we have sent through the quality delivery system service assessments to this meeting, I think they've also been looked at in the People, Culture and Leadership Committee. Whilst I think the plan is that they will be published on the Trust website, and that will happen. But I've also been reassured and assured through the meeting that this is an area that we continue to look at. As EDI lead for non-exec lead on the board, it is something that we are I am mindful of, and we will continue to be cognizant and look at how that is picked up in the delivery of future work as well. So I'm happy to take questions.
So, very comprehensive update. Any questions?
Just a very quick one. Chaplaincy, because this is the first time that I've seen a chaplaincy annual report mentioned. I'm just wondering what the partial assurance, what are the challenges for chaplaincy in relation to the assurance rating, which is partial?
That's fine. So this is, I think that it is the second report that the committee has received in relation to chaplaincy. The issues in terms of the assurance, the team are working on being able to demonstrate their levels of activity so that we can give a greater level of assurance then to the committee and to the board around the numbers of people who we're interacting with from a chaplaincy perspective, and that informing any kind of gap analysis that we might need to do. So that's one area. Secondly, the other area is around the strategic approach of the chaplaincy team. So that's something that they again have been working on and developing is our kind of chaplaincy strategy, if you like, and work plan for the year. So that was kind of partially outlined, I think, within the paper, but outlining kind of what steps they need to take in order to further develop that. That's why it's an assurance.
And can I just get some reassurance, rather than assurance, that it is a multi-faith chaplaincy, spiritual offering, rather than just a
absolutely, yeah, it is absolutely a multi-faith offering.
So mindful, we're running about 20 minutes late. Any further questions on the paper?
Really quick one.
Yeah.
Where does freedom to speak up, and to what extent does that impact?
So Freedom to Speak Up reports regularly through to quality and safety, and also links through with the meetings that sit beneath it. And then as individual executives, many of us have one-to-one meetings with the Freedom to Speak Up Guardian as well. So if they're picking up, if the Guardian picks up any specific things within our portfolios, then we will deal with that separately.
Thank you. Right, so we've got two reports coming up on safety, effectiveness and experience, and also the integrated quality performance report. Just to note that both of these papers have actually informed our risk register, and also look on the basis that we've read both papers. So take the first paper first, then safety, effectiveness and experience report. So
Thank you, Chair. Just 3 items that just wanted to flag to the board today, and I will be brief. So the first is with respect to Triangle of Care and our work with carers. To inform the board that we've retained our 2-star accreditation with the Triangle of Care scheme. I will remind the board that whilst there are 3 stars that you can gain as a mental health only trust, we can only ever have 2. So we are achieving the level that we would expect to. We had very positive feedback from the Carers Trust around the strengthening of our approach to Triangle of Care, and particularly noting the work that we've been doing with our experts by experience to benchmark ourselves against the standards to make sure that we are not effectively marking our own homework in terms of our engagement with carers, and that will continue. The second area that I wanted to flag is a more general point around patient safety. The board will have noted that we have previously reported on numbers of overdue actions related to incidents, patient safety reviews, and old patient safety incident investigations being open longer than we would want them to. We are continuing to see a decrease in the numbers that are open and overdue, and are on target to reduce those to the levels that we would expect in terms of having open but not overdue PSRs, patient safety reviews, and patient safety incident investigations, and that is all on track and going in the right direction. And the last is to say, again, I've reported into the board issues with our compliance with duty of candour in previous months, and to provide the board with the assurance that we met 100% of compliance with duty of candour in February, and will continue to monitor that compliance through the committee. So I will pause there and take any questions.
Jan.
Sorry, just a very quick one. Patient safety, so that same paragraph 14, just says in February we saw an increase in catastrophic death stroke incident reports, and I'm probably should be looking at Sarah C here, which is, so we're consistently higher now than what we were in October 25. Just wondered whether you could say anything about that. And secondly, just very quickly, that doesn't then correlate with the graph below in terms of, I thought, if I read this correctly, the black line is a graph below which shows a decrease from 108 in January to 81 in February. Am I looking at the wrong thing? So 2 questions.
The first one, you'll see that highlighted also in the mortality report that's tabled to this meeting, that there is a significant increase in the number of deaths that we are reporting, which has come into place since October 2025. So all of the data is consistent with that. And that is because we've changed the processes in October to widen the area and to seek information about patients who had died who had previously been under our services. And so it's a combination of, so these are people who we wouldn't previously have even been informed about, and we are seeking information and going back through Rio, and also because you can see a tag on Rio from the national spine if somebody has died, and so we are including those in our numbers. So the numbers appear to be increased, which they are, but these are just people that we now know about that we weren't reporting on before. And we're doing that in order to try and maximise our learning and to widen that so that we kind of capture more information than we would have done rather than being restrictive. But that's covered in the mortality guide. Oh, the numbers. I don't know the answer to that, I'll be completely honest.
Do you want to take it away?
Yeah.
Yeah? Thank you.
It does show in the mortality report.
Yes,
itself.
it does. And so this was just a bit different.
Yes.
I think that's why it's there, but we'll take that away and clarify.
Thank you.
Any further questions? If not, we'll then go on to the month 12 integrated quality performance report, which again has gone through all the due processes. So any key issues?
Thank you. I'll start from a quality perspective and then I'll hand over to Matthew. So one issue that I wanted to highlight to the board, and it links with thematically the issues that ELA raised through the Quality and Safety Committee reports and that Dominic raised in terms of bed pressures. We have seen some of the quality impacts that we were monitoring as part of our reduction of out-of-area beds start to emerge. So we are very aware and very closely monitoring those possible quality impacts. So we saw an increase in the number of mixed-sex accommodation breaches, which is where we might admit a patient to a bed of the opposite, that would normally be designated the opposite sex. We also saw some admissions to ward types that were not necessarily the most appropriate ward type for that service user's needs. So, for instance, somebody with an older adult with a functional mental illness being admitted to a ward designated for dementia. And whilst mitigations were in place for all of those quality and safety issues, nonetheless we had seen an increase in them as a possible outcome of our work to reduce out-of-trust beds. We also saw some issues being reported to the divisional leadership team in BNSG, so our staff reporting that they were feeling uncomfortable about some of those issues that I've described and feeding back around some of those decisions that were being made. So we took some immediate action to understand that in more detail. We've met with intensive teams, we've met with ward managers, and we've met with modern matrons to hear their feedback. We've also met with consultants from the inpatient wards and the intensive teams as well. You will have heard from Dominic that obviously we have also seen now, unfortunately, an increase in the number of out-of-trust bed usage. And we have reviewed and refreshed our approach to our kind of grip and control, I guess, around our admission processes. We've implemented, or in the process of implementing, a new approach where we will trial and test using QI methodology some of the ideas that our clinicians have had that may further improve our flow through inpatient services, and that will be a clinically led piece of work which Sarah is leading for us, and we will be able to provide further information about that as we move through that piece of work. We have now seen the reduction again, so we have not seen a sustained level of mixed-sex accommodation breaches or admissions to other wards, and so I present it here as an example, I guess, of where we have picked up on an issue as part of our quality oversight and addressed that swiftly and continue to be alive to those issues. I would just also add to that, this was an area of discussion that we had when I was talking through the board papers with our strategic expert by experience groups from the carers and the service users perspective, and considerable discussion around the impacts that sending service users out of trust can have, but recognising that balance with the need for safety as well. We talked a lot about alternatives to admission, and the experts by experience really pushing us to work closely with our local authority colleagues, recognising the positive impact of actually having packages of care within a home setting as alternatives to admission, and also recognise the impact that can be had for our service users who are admitted sometimes for longer than we would like to acute hospitals prior to being transferred to one of our beds. So a really a strong sense from our experts by experience that it's the right direction of travel to look at this area, but that we should also be mindful of the quality impacts. An area that we will look into further that came up from our experts by experience was perhaps looking at admissions based on those people who are potentially waiting for a particular modality of therapy. So we're going to explore that a bit more and feed that back as well. So from my perspective and quality and safety perspective, I will pause there and we can take questions on that particular issue, or I can hand over to you.
Any questions for Sarah? Lizzie?
This isn't a question, I just wanted to highlight the fact that we had quite a good discussion, I think, in quality and safety about
our recording of protected characteristics data, and the fact that there is an amount of work that needs to be done to address the poor performance.
Yeah.
Which case then, over to yourself, Fatty.
Thanks very much. I'm not going to go through everything, just want to pick out a few things that are kind of salient to board interests and delivery of our strategy. I just wanted to flag a recent update on progress made around the BSW Urgent Care Service. So that's to do with the provision of NHS 111 and Press 2 for mental health option. I'm really pleased to report a significant steps improvement, because we are now have a call handling and telephony management system commissioned through a partner called Bristock, and are experienced in delivering NHS 111 services with us in partnership in BNSSG. So we now have a comparable system set up as a temporary piece of procurement for a period of 12 months for BSW as well. That's also enabled us to significantly improve the clinical oversight, supervision training and monitoring of how we deliver the clinical assessment service in BSW, so operating in a much more integrated way and a much more resilient way, because those services can now cooperate and deal with spikes in demand collectively rather than as completely separate services, etc. So we will be taking the next steps of looking at the long-term solution for that service in the coming weeks. We took a paper executive team yesterday, so some really steps of progress, I would say, and thanks to pretty much all corporate departments in one way or another have helped us get that over the line. So thanks to everybody involved on that, and we'll look forward to being able to present some really good quality data going forward, because we will have all the automation available to generate that for us. So that was one area. Sarah talked about inpatient services, which is the other area I talk about nearly always in these meetings for a long time. I just wanted to flag a slightly different area, which is around talking therapies. So colleagues might remember that we'd had a contract performance notice imposed by BSW Integrated Care Board. I'm really pleased to report that's now been lifted, and we're seeing sustained improvement, and there's really good data for talking therapies where you can see incremental month-on-month improvement where you want to see that, and sustained improvement. We are just very slightly below the total number of courses of treatment, sort of ambitious target, and that has gone up as well from the 1st of April, but still seeing that something which they've basically doubled activity in that service, and that's with really good clinical outcomes and waiting times as well amongst some of the better for that type of service. So we'll continue to push forward just to make the final progress to achieve the total numbers of courses of treatment. And the only other areas on the flag that I don't often mention were just around secure services occupancy, so we can see some improvements there, and some of that has come about due to making decisions around how we use Carey Ward, our learning disability ward, and increase the number of service users there, and the ensuring the high levels of occupancy is an integral part of delivering our financial plan for that service. So some good progress there across clinical and patient experience outcomes that have got a financial outcome to them as well. So that's all I was going to say, and happy to take questions.
So, any questions, colleagues? Jan?
Just a comment. The Project Zero information that we've got on the paper, that was really heartening to read. I'm just wondering whether we could just, if you can give us an update next time in terms of where we, as required, in terms of where we're going with that, because it's positive.
So I've got Brian and then Ela.
Thanks, Chair. Can I just check on the NHS oversight framework, because I don't remember if we're able to cover this in Q&S or not, but the decrease from Q2 to Q3 on the patient safety segment, do we fully understand the reasons for that? Because the commentary seems to suggest that maybe we haven't improved as rapidly as the NHS England average. Just, are we fully assured that we know what's going to happen, so it's not a risk to the future?
So, Matthew?
I don't know the answer to that in detail, Brian. I think it's something we need to look at to understand exactly, because as you're right, it maps against other providers. It's not just about what we've delivered on our own.
So on this one, I was going to raise a question on the national, or the NHS oversight framework. I know we've had previous conversations about how potentially flawed the metrics to measure performance are for mental health organisations, and how it doesn't reflect us as an organisation in the entirety. But also there was conversations about the national oversight framework metrics might be updated in the future. So could I suggest that the Finance Planning Performance Committee, at one of their upcoming meetings, go round the block and have a conversation about the National Oversight Framework metrics in light of any potential improvements that will be coming downstream in the summer, because I look at this and I don't recognise the organisation I chair. And when I read the papers for today, I was heartened by certain things, you know, effectiveness and experience, and I'm looking at Appendix 1 here, and heartened by patient safety. But if I look at the scorecard in Appendix 1, I'd be thinking, heck, there's something going amiss here. So I think there's a misalignment of how we're measured by this, which picks up Brian's point. So can we do the heavy lifting at the Finance Planning Performance Committee, please, James? I'll have a chat offline with you about it. It's a well-trodden path, but we need to go and walk that path again, I think. And I'll pick up your point, Brian, hopefully. Ela.
Brian's asked.
Brian?
Yeah, thanks for that, Paul. I mean, just to come back, experience suggests that even if the NOF is being updated in the summer, which is likely, and even if there's some misunderstanding about how relevant it is to mental health, there's always someone at NHS England that just looks at the numbers, just to register that for the board.
Final point, Sarah.
Thank you. It was just to note they're very limited number of indicators that are measured, and in both the effectiveness and experience and the patient safety, one or two of the four are only updated on an annual basis. And whilst we do know where we benchmark with respect to both of those, they do only update on an annual basis, and so we will expect, if they are still indicators in Q1, we will expect those to update them.
Loveday, is People, Culture and Leadership Committee Chair's report.
Oh, yes, it's me. I'm here. Oops.
I know, I thought.
Okay. Thank you. Let's open my notes here. We've had 2 meetings of PCLC since the last committee. First one was on the 16th of March, which you've got the paper for here, and then the second on the 6th of May, which you haven't got the paper for yet because they're not typed up yet. In terms of the 16th of March, just going to draw your attention to 3 areas. 1, workforce. We are sitting with substantive staff at 93%. Turnover is relatively stable, really better than what we've had in the last few years at 10%, and we seem to be having strong appraisal figures as well. I'm just going to throw out here, which isn't in the report, but a reminder for NEDS to do their Statman training, please, to make sure that we maintain that compliance. Well, not everybody has. Okay, so moving on. The Public Sector Equality Duty Summary Report was received. It was recommended to come here, which it is on the agenda today, for approval by the board. And the third thing that I want to draw your attention to was the post-incident support plan that we discussed during the meeting on the 16th of March, although I wasn't there, and that will be returned to the committee once we see from the Deputy CNO to see how we are supporting staff. The meeting on the 6th of May, which I haven't got the papers for yet, just want to flag a few issues for you. The risk oversight, violence and aggression against staff remains at 12. We did discuss that in the committee, and we'll bring it back next month to see whether we will be reducing the risk rating or not, but we'll do that in the next meeting. I want to alert the board to the inclusion and wellbeing strategic objective. That has been it may be increased during the next meeting following the EDI internal audit report, but we will update the board accordingly. Workforce planning, we are seeing and noting a sustained vacancy reduction position. Turnover actually is below 9%, or between 9 and 10%, and that is, I think, phenomenal for the trust that we have had, you know, challenges in relation to turnover and substantive staff in post in the past. And we have got a very strong recruitment pipeline, and I think that's credit to the people and the nursing directorates or divisions, I think. Workforce pressures, medical staffing here at Salisbury is a challenge at the moment, and again that obviously is on the agenda for us or on the radar, I think, for the organisation to hope that we can improve. And I'm just glancing at Sarah, who's looking straight ahead. We received assurance in relation to Tame wards. That was around the previous quality and safeguarding concerns. They were addressed as appropriate addressed with appropriate oversight and governance in place, although it's really a QSC situation rather than ours in PCLC. Finally, we received assurance in relation to the Guardian of Safe Working and the responsible officers arrangements last month. The committee terms of reference were revised to incorporate representation on the committee from Martin and Loveday, so that we can ensure that the transformation programmes address the workforce challenges, or not address the workforce challenges, but we keep an eye on them across both committees. Finally, I just want to say, in terms of advising the board, we have continued oversight on the medical workforce sustainability. In relation to workforce matters, they're reported through the workforce planning update and then come to us. There is a consistent divisional director engagement, which will be reviewed in the future in relation to the well-led aspect of the plan that we had following the CQC visit. And that is all I'd like to share.
Okay. Any questions from colleagues? Lizzie?
Thank you. It's about the 16th of March meeting, so and it was to try and reconcile the risk information that we had about the immigration challenge with what's recorded here. They don't seem to match, and is that about timing?
Yes, 2 months. So yes, so back then we were being probably risk averse. Things weren't going so well. Since then, the situation improved. We also realised that the risks that were going to happen. So if we had insufficient healthcare support workers, if we had problems recruiting, if we had new gaps, that wasn't happening. We were filling our gaps in workforce with new staff, with bank staff. So impact on the organisation of the immigration issues is minimal.
Right.
The risk for the individuals, of course, is still horrible. But that's what evolved over the 2 months.
Right, thank you. I suspected it might be a timing thing, but that's helpful to get that context.
And Neela was on the same
page? It was on the same point, but to raise the point, while we recognise the risk and the management of the risk in terms of vacancies and recruitment and filling those vacancies, there is an impact on those individuals who are affected, and we just need to recognise that. And I was really pleased to hear about some of the support that is being provided to them and their colleagues who are equally upset by some of the decisions that are outside our control.
Julian?
And just for, actually I'm not going to say that because it's public board now.
Okay. Hold that thought for later. Okay, on now to Digital Estates Committee Chair's report, Loveday.
Great, thank you. I will keep it quite brief. We've just had one meeting, which you've got in front of you. On the estates compliance, we had quite a long discussion about that because there is a particular part of the estate which is not so compliant, primarily due to overdue asbestos inspections. But we satisfied ourselves that there were some actions underway to let those controls to a third-party provider, and that would then bring that part of the portfolio into a much better place. So that was very good. We signed off a new terms of reference to increase the scope of the group to include transformation, as we've spoken about previously. We had the risk conversation, which alludes to the point I made in the risk report about the sort of realism of the long-term targets that we were going for, and agreed, as we've said, that cybersecurity probably was something that was not going to be brought down to the kind of level that was in the risk register at the moment. We talked about AI. The key thing for AI is, although there's a lot of enthusiasm at the moment for the various pilots, it's the degree to which that can be systematized and turned into efficiency and productivity savings, which I think the jury is out on that. We talked about the trust capital plan, and whilst that's being managed through Finance and Performance Committee, the committee was particularly interested about the capacity to deliver transformation projects and programs and capital schemes, so that actually we can spend all of the capital profile that's coming into the year ahead. And so we'll be taking some interest in that in the future. And then lastly, we talked about the transformation blueprints, some concern over the delay to the timeline. But at the same time, I think the committee was very pleased that there was executive engagement, and thought it was better to be patient and wait for them to be done really robustly and properly, so that the right executive sponsorship is there and they are good plans. And we look forward to receiving and scrutinising them in due course.
So, any questions, colleagues, on the TED committee update?
Very quick question from me. Just wanted to understand a bit about the governance framework that's in place for AI.
Martin, do you want to talk to that?
So if I pick up on in the first instance, the technology side is what we are evaluating at the moment. Alongside that, we will have to look and say, how do we actually deploy this? And this is where the questions are at the moment. So as it stands at the moment, although we've got pilots, they're learning pilots. So the intention is, what is effectively the impact of this? What do we need to do, and how do we build sufficient controls into the next stages of the deployment of it?
Thank you. So I've got a quick question from Donna.
Just a quick comment on the terms of reference. Apologies for failing to make sure that we actually had the updated terms of reference attached, so that the board would approve those amendments, which it does need to do. Obviously, you can reassure the board that that's not going to cause any delay in the actual oversight the committee is doing with transformation, but we will make sure that that comes through for ratification by the board. Probably attached to the committee annual report when we're going through the terms of reference anyway. So all the changes the committee's distributed oversight of different aspects of transformation will come through for the board to ratify.
Thank you. So next item now is Audit and Risk Committee Chair's report.
Thank you, Chair. Just a couple of items to draw your attention. It's that time of year when the head of internal audit, our internal auditors, RSM, say that, quote, we have an adequate and effective framework for risk management, governance and internal control. That means effectively that we are amber green, the same as I think the last 2 years. This meeting was 5 weeks ago. We've got another audit committee in 2 weeks' time, and I'm assuming that the head of internal audit report will be the same. but that's when it gets confirmed for year end. I'm sure Simon and I would have heard something to the contrary from RSM if that was not the case. We also approved the internal audit plan, just to thank the chairs of committees that gave me their feedback. For the last couple of years, in order to triangulate, I've asked the other chairs of the assurance committees to have a look at the draft internal audit plan, so that's coming back. Also, just to flag for your interest, coming to the next audit committee meeting on the 28th of May will be what we call the audit assurance map, which is a more detailed document that shows where the 3 levels of assurance come from and how we can assure that. The NEDs that have been here a few years will know what the audit assurance map is. Those of you that have been here for less time, I don't want to spoil the excitement of next Monday afternoon. Just a note for interest that under LCFSS, which is Local Counter Fraud Service, again, it's that time of the year, we have submitted the counter fraud functional standard. That has to be signed by me as audit chair and by Simon as the responsible officer and chief finance officer. That was signed by us, I think, last week, Simon, and that's an overall rating of green, which is a good level of assurance. Then also just to note the next paper, the Emerging Risk Radar. I think RSM put this 3 or 4 times a year, can't remember how many, but I thought it would be useful to do a little bit of that blue sky thinking, that when we look at our corporate risk register, or particularly the board assurance framework, this gives us some idea of benchmarking what RSM are seeing across their client base as potential emerging risks. And I think if you have the chance to read through that, you won't see any surprises or anything, particularly on the board pack 107, where you've got that sort of pie chart. I don't think there'll be anything there which we are not aware of for our own risk registers and board assurance framework. So just to draw your attention to that useful document. That's all I need to focus on, Chair, because this meeting was 5 weeks ago. Got a new one in 2 weeks' time.
Thank you. Any questions, colleagues? Ela.
Thank you, Brian. I think this is a question for other colleagues. I was curious, BSW risk register, so there was partial assurance on the improvements required on the process to manage this, and was just wondering what would help you get significant assurance on the process, and by when do you expect to see that significant assurance?
Shall I answer that first? Because we did have quite an in-depth discussion led by BSW team, prompted by interesting questions from the NEDs and also supported by Sarah. But the general feeling was that if we want to be assured on a process, there needs to be evidence that it's embedded, and there's lots of excellent changes since they last submitted to Audit and Risk Committee, I think last September or October, but we just wanted evidence of embedding of actions before we felt, or they felt, that we could move up to the next level, which of course will be significant assurance of minor improvements required. That was their thought, and Audit and Risk were happy to agree with their assessment.
Thank you.
Okay. Just to let you know, I thought long and hard about dumping James in to do the verbal Finance Planning Performance Committee update, but then again I thought no. So there is a paper on part 2, however, and we'll cover it there. So on now to finance report for month 12.
Yeah, thanks, Chair. So obviously at the last board meeting, I did report around the March sort of financial sort of position, given the fact that we're now in sort of May, and reporting on sort of the month 1, but clearly that will be picked up in the next Finance Committee. So it does feel a little bit out of date now, but I can confirm that the Trust achieved its sort of financial sort of target of break-even, but also that it was received additional funding from the redistribution of national deficit support funding. That came about from systems and providers who didn't deliver their financial targets. The deficit support funding which had been allocated to them was removed, and then redistributed to the systems and providers who had achieved their plan. So we received 1.6 million to be able to improve our financial position and to report a surplus. That surplus was cash backed as well, and will help our cash position, whether that is to support capital expenditure, which isn't backed by by cash in the future, or dare I say, if we become in a much more financially challenged position, clearly cash will be a key aspect of that deteriorating sort of position. I can also report, again, in line with our sort of financial planning and the plan which we've got for 26-27, we delivered all of our savings programme, but of which 74% of it was on a recurrent sort of basis. The key element which was rolled over into 26-27 related to the out of area sort of reduction, which equates to about £4.2 million. And clearly, as reported earlier within the meeting, that is an area where we will need a particular focus and attention given the pressures that we're experiencing operationally. The third element that I just wanted to highlight, and again, was concern raised by the board and particular focus within the Finance Committee and Audit and Risk Committee was around sort of capital expenditure and the delivery of the capital target. I can confirm that we achieved that sort of target, 22.9 million. We will, and obviously that included the purchase of 2 properties as well as the planned purchase of a crisis house, and all of those, again, as reported, have now all sort of been sort of completed. The other national sort of target, which we've delivered on an annual basis, and we continue to do that, is our Better Practice Payment Code, and again, against a target of 95%, we are just under the 100%, and again, that's in line with what we've seen in previous years, and again, it's a good demonstration of our strong sort of cash position. So yeah, happy to take questions.
So, any questions, colleagues? So once again, a successful year financially, but the show rolls on to future years. Now if we move on to the internal operating plan for 2026-27.
Okay, so Simon and I have jointly overseen the development of the operational plan. As we have briefed previously, we have a responsibility to provide to NHS England our internal operating plan, but on an annual basis, but this time over a 3-year period, which has been different historically, because normally we've had to produce this on an annual basis. The Business Planning and Service Development Group are the group that oversees, and if you remember back to our diagram showing our governance-wise, the BPSD is the group that controls effectively what we do in terms of us responding to and creating the operational plan. As part of the BPSD process, what we've done is engaged with the directorates, and we have created a plan based around the categories that you've seen in the report, namely neighbourhood and community, inpatient, crisis, specialised secure and CAMS, digital, and also the enablers. And what we've done in this particular paper is to set out the projects that are associated with the operating plan and how those then connect out to the organisation's overall strategy. I wasn't intending to go through in specific detail, but it was just to say from an assurance process, governance-wise, the Business Planning and Service Development Group have signed this off as their creation. That has then effectively gone through the process internally within the directorates up to the executive for final sign-off, and we're submitting it here for the endorsement. I'll stop there, Simon, unless there is something else.
So just a couple of other elements just for the board awareness. So obviously all of these elements will then link into the board assurance framework and will reflect as the actions that and the objectives that the organisation is undertaking in our quest to be able to deliver the current strategies for the organisation. The other element which was presented to sort of Finance Committee was the profile sort of capital plan, because of many of these elements are all part of our capital programme. Again, that's reflecting some of the weaknesses and challenges that we've seen in previous years, and particularly last year, about the delivery of our sort of capital plan. And again, the committee took assurance sort of on that. Clearly, that profile isn't presented sort of within public because of the sort of commercial sensitivity of some of those numbers. But again, I think it should be minuted and noted that that is now sort of in place and will be picked up and reviewed through the Finance Planning and Performance Committee, but also, as Loveday talked about, within the Transformation Estates and Digital Plan, given the fact that many of those elements sit within that area.
So this is a paper we're asked to approve, but before we have the conversation, just also to remind people, on page 123 in the cover sheet, it talks about prior discussion and outcome. So as a board, we've been involved quite extensively through the journey of this plan, through board seminars, through a board part 2, through various committees. So this is kind of the culmination of the process. And it's the public culmination of the process that we've all been involved in and we're all party to, and with key submissions we've all signed up to prior to them going to the regional office as well. So this is the end of the journey. It's something we've been part of. So any questions or queries, colleagues?
Can I just add one more thing? So obviously this is all of the additional elements over and above business as usual. So, you know, again, people might think, if they were reading this in isolation, be thinking, hang on, you know, what about all of the work that we do around safety, delivering against our budget? These are the things which are over and above, and many of which link into the transformation of our sort of services, particularly around the digital side and also the estates element.
So any questions or queries? And Jan, you're pondering.
I am. I'm full agreement with this. It's just, you know, when our strategic objective is, it's probably not for here, but it's probably for a board seminar. But so I just want to flag it as something to take forward. Where we've got our 4 strategic objectives and we've got delivered in partnership, and in our internal plan here, the partnership delivery is all it is co-collaboration with partners and service users, with just the add-on that says something about partnership outside, that gives an inference of the partnership outside of the trust. And I just wondered whether it's something we need to take forward to actually make it explicit. So we've got 2 sentences in the partnership strategy, one with service and users and staff, and then the other with partners to deliver the services, because otherwise we're just looking internally and we're not making reference to the work that we want to do more strategically with partners to ensure that the services are delivered for the community. So it's not for now, but it's for some. I just want to flag it up because it's just missing.
So Martin?
The partnerships will get picked up as part of transformation, because when we look ahead into the future, the opportunities for shared service type working with other organisations are a significant opportunity around transformation. At the moment, we are looking at ourselves and how we're transforming ourselves, but I think what we also have to do is open up that to that much broader partnership.
Absolutely.
So there will be other discussions about this.
Yeah, so all I'm saying is that it should be in our strategic objective. We could name it in there, that's all.
Yes.
And just to build on that before bringing Sarah in, I've had some conversations with Dominic about how we lead ourselves, and there's a piece of work about potentially refreshing our strategic objectives and the pride values and all of that. So there will be a conversation with the board looking at what is our overarching strategy, what are the underpinning values, how that then links through to how we organise ourselves to deliver those in terms of leadership arrangements. So that's a piece of work that I think, Dominic, you're thinking about the best way of engaging the board in that conversation.
Absolutely, and I can't quite see Julian because he's right down the end. Julian and I have had a little exchange about that. We'll probably bring something into the board. I think we were talking about August time to just consider, discuss, and agree how we lead through this period. And if I can just, since I've got the floor, just to say, Jen, I completely agree with you. I think that statement is insufficient for what we're doing, so we probably just need to refresh that statement because there's so much more going on than is described there.
Yeah.
So shall we, with the board's agreement, strengthen that statement for this document? If colleagues are happy with that? No, Donna?
Just to say, don't disagree with what's been said, but just this statement comes from our strategic document, it feeds into the board assurance framework, etc. So it wouldn't just be for this document. If we're going to say this needs to be strengthened our strategic objectives, quite happy that we do that, and as a board decision, we just need to filter it through to the other places.
I'm happy if you're happy just to tweak it and strengthen it in line with what you say, because I'm just seeing nods around the table. So it's a bit of a follow through. Are you happy to follow that through?
Yeah, of course.
Sarah, you've no patience.
That's okay, no problem. So I just wanted to inform the board, this was another area that our strategic experts by experience were really interested in, and we spent some time talking this through. They were supportive of the approaches that we were taking. They were very supportive of approaches that talk about earlier intervention, and I think that aligns with the presentation that we heard earlier today from Angelina as well, around the importance of that and timely intervention. They felt that there was work that we could do further to, as they described it, sell the community as the best option. They said their perception, and this was fairly universal, was the way that we talk about community is almost as if it was a sort of inpatient best, community second, which was really interesting. So we're going to kind of take that forward and think with our clinicians around how we frame some of those conversations as well. They also felt that the strength of linking in with community assets and carers and support networks should be embedded throughout as well.
Lizzie?
And apologies because I think you may have had this discussion earlier in the process when I wasn't part of the board. But I'm conscious that this is like a 3-year plan now, not a 1-year plan. And given that longer time scale, what I didn't get a sense of is where the oversight of it being delivered happens. I'm assuming it's going to be in a from a committee perspective at the Finance Planning and Performance Committee.
Well, there's going to be multiple committees overseeing components of this.
Well, where will that? Yes, but so where will the oversight of all of that? Because if it's spread like that, there's a chance that things are going to slip.
Yeah, so one central report quarterly on the whole internal operating plan comes through Finance Planning and Performance Committee, but it's also attached to the board assurance framework. So each committee receives that summary with the focus on their specific objectives and elements within that.
Okay, thank you.
It is a good thing. Do you have a separate committee that looks at it, which disempowers individual committees? So we've got a link in there.
Yeah.
Right. On that basis, are we happy, colleagues, to approve?
Yeah.
In which case, it's so approved. On now to the Chair's report for noting. Edith's already said that we should be updating her activities for the next report. So on that basis, are we happy to note? If we now move on to Learning from Deaf's Quarter 3. And these are papers for information, by the way. So any kind of key issues that people want, or do we just note?
Only to note that triangulation with the previous question about the rise in reporting from October 2025, which is consistent in this report.
Can this is a bit of a picky question, and I apologise because I only it struck me yesterday. I would have asked you outside the meeting, but it's on page 146. And it says, it's talking about the dashboard. The aim is that this dashboard will be live by Q1 25-26. Are we not in Q1 26-27 now?
Apologies, I'll change the date.
Is that...
I tell you, it's always nice to have one really conscientious non-executive who literally reads everything. So thank you. Brilliant. Acknowledge that again. Great. On now to the Safer Staffing Annual Report. Again, it's gone through Quality and Safety Committee in detail. It's coming here for noting because there's an expectation it does come through to the board as per the previous paper. Any questions for Sarah? Or any issues, Sarah, you really want to highlight?
Nothing specific. Happy to take any questions.
Just a quick one.
Jan?
The financial impact. There was a slight, well I say slight, £10,000, which is slight in comparison to our budget, financial impact. Can we absorb that? I know the answer is yes.
Well, Chief Financial Officer, so reassures me, yes.
It's 9,000 something, I think.
Sure, we can find something.
And I had the conversation with Paul Spencer as well, in terms of affordability as well.
Thank you. Really good actually.
Okay, so we note that. On to the next paper, which is I'm just going to do the abbreviation, the Equality Delivery System EDS 22 Domain Report. Now it's got here for approval for publication on our website. Any comments, colleagues? Again, it's gone through Quality Safety Committee. Any comments that people have on the paper?
This is a comment, this isn't a question, and it did make me think when I read the paper that it would be important to see some of the issues that are in here addressed through some of our transformation plans as well.
And I'm assuming the richness of the organisational backstory, the richness of our understanding of how the AWP ticks is all brought to the table as part of the engagement with staff in transformation. But again, the executives in your oversight, if you can help triangulate that as well. I think that's about the best work we can do. Yeah.
I was just going to say, but if we aren't collecting the data, how will we know?
So, Sarah?
So there are some specific areas that we're focusing on. For example, in the Mental Health Legislation Committee, we've started to include that ethnicity data to look at. So what we're not doing is saying we're not collecting all of the data and therefore we won't, but there are areas where we do have much more robust information, for example, using that, so we will.
Yeah, I'm making a very generalised point, which is to remind us that actually there's a lot to be done.
Yes.
Still.
And we're tracking the data that point about collection of data. We're tracking that and looking and challenging our divisional colleagues on that in our performance report meetings.
And it was assuring to see some of that detail in the IPQR. Although the thing that struck me was collecting disability data seems to be difficult for everybody, and I'm curious as to why. And secondly, if IAP services could achieve 100% in collecting all of the data, what stops other people from doing the same?
So some of us are smiling because we've been around this loop
we're smiling.
so many times.
The question of disability is a pet question of mine, and I'm with you on that one. I haven't got the answer yet, but I can assure you that it is a question that is having focus. The issue about the IAP, that is directly related to the systems that are used. So IAP uses a different recording system that comes up with prompts that you can't get past. It is a positive prompt to you, and you can't get to the next screen until you've answered it, and it's done in a different way. Whereas on Rio, it's something that has to be driven by the clinician and then isn't even all in one place. So it is harder to record. That doesn't mean that we shouldn't be asking people to ask, but it's a very different system.
Just clarifying, IAPT is our talking therapies service.
Oh, what did I say? I'm so sorry.
We're using IAPT, which isn't the current name, and also it's an abbreviation, so I'm just clarifying.
Sorry.
If I don't know what it is, I like to answer it better.
So, are we happy then to approve the publication of this document on our website? Thank you, colleagues. Any other business for part one? In which case then, let me know any other business. Can we conclude the part one public board meeting, and can I thank colleagues for your engagement today? And then we'll continue with the charitable, the board as a charitable trustee in a brief moment.